So today we're going to start perioperative nursing. And the very first thing I want to do is show you a video.
Today we're going to be teaching perioperative nurse interns how to be operating room nurses. These are nurses that have graduated from nursing school and they're learning how to be nurses in the operating room. We will teach them how to scrub their hands. We will teach them how to do a surgical rub, which is an alcohol antisepsis on their hand. We will teach them how to gown and glove. We will teach them how to gown and glove a surgeon. We'll teach them how to set up a table, all the instruments, how to count the instruments. Then we will teach them how to put the drape on the patient. We will teach them how to hand instruments to the doctor, and I usually play the doctor. We work on universal protocol, which is our timeout, and we work on a fire risk assessment, which is very important in our patient safety.
We're going to start putting our drapes up here, our gowns for the doctor. Container is where you put your blades and your sutures. All right. That's nice. One, two, three, 4, 5, 6, 7, 8, 9, 10 Ratex. Okay. 2, 4, 6 needle holders. 2 right angles. 2 curved Adsons.
Good morning, everybody.
Ready.
Hello. We're going to clip them.
We will take our time out now.
I'm Dr. Fitzgerald.
I'm Erin, I'm the circulator.
I'm Eileen, I'm the scrub nurse.
I am Mike, an anesthesiologist.
This is Mr. Jones. We are going to do an exploratory laparotomy. There is no side. He is in a supine position. We have our x-rays up on the wall. We do not need implants. There will be a specimen, and we will be about 2 hours, and I think it's going to go pretty well today. I think we're going to be fine.
Patient is an ASA 1 gram of ANSAP given, the access on the left arm, blood products are hanging, and there is no special concern.
Our equipment is sterile today. We have normal saline for irrigation and use a fire risk assessment of 1.
Knife, please. Hemostat, please. And DeBakey forceps, please. Thank you.
Raytech, 1, 2. 3, 4, 5, 6, 7, 8, 9, 10. Count is correct.
Okay, so I wanted you to see that first so you have some idea of what goes on in the OR. So let's start our presentation and we'll talk more about each of the roles of the individuals within that OR. Now you yourself may have been at the operating theater, or you might know somebody that's been in the operating theater. So perioperative nursing, it includes care that is provided before, during, and after surgery. Sometimes a surgery can be scheduled or a surgery can be elective. So we have time to prepare the patient. The longer we have to prepare, the more information we'll know and the better equipped for that surgery that patient will be. So a nurse working within that perioperative setting must be able to respond to complex and changing clinical needs. So they have to recognize signs and symptoms of malignant hyperthermia. They have to notice risk factors before surgery, like if the patient is obese and their risk for dehydration, or the patient is very thin and their risk for skin breakdown. So that nurse has to have a plethora of information to prepare her to accurately care for these patients in the surgical experience. So as the length of hospital stay decreases, the education needs of the patient undergoing a surgical procedure increases. So we have to ensure that we teach them everything that they need to know to be prepared to be either discharged home or to a rehab facility, or as they are sent to the medical surgical ward to have a stay there. They still need the education on coughing and deep breathing, pedal exercises, those type of things, use of the incentive spirometer. So surgery, no matter how minor, causes stress and anxiety. It also poses risk and complications. So whether I'm having an elective nose surgery to repair a deviated septum, or I'm having cardiac surgery, both of those surgeries are going to have some form of complications and risks. And it's going to cause me stress regardless if it's a minor surgery or major surgery. So nursing goals when caring for any surgical client is to minimize the anxiety, prepare them for surgery, and assist with that speedy, uncomplicated recovery. In doing so, we have to be able to assess for changing status of the patient. So perioperative is the entire span of surgery. It's just not the beginning or during the OR. It continues to post-op, and it continues through their discharge home or until they're sent to a medical ward. So perioperative begins with the decision to have the surgery. So as soon as they begin to have surgery, we have to start to prepare. What labs will they need? What diagnostic tests will they need? What teaching do they need? And continues until the patient reaches the operative area. And that begins the intraoperative phase. And that's the entire surgical procedure until they're transferred to the recovery area. Once they're in that recovery area, that begins post-op. And that begins with the admission to that recovery area and continues till the client receives a follow-up eval at home, or is discharged to rehab, or sent to the medical surgical ward. So we need to talk about types of surgery. So there is purpose and reason for surgery. So we'll discuss each of these in a little bit more detail. But there's the degree of urgency of the surgery. That's the necessity to preserve the client's life, body part, or body function. So how important or urgent is that surgery? Can we delay the surgery, or is it imminent and it can cause death if they don't go to surgery now? Then the degree of risk. That involves like all the client's factors that can put them at risk, like their age, their general health, any comorbidities, their mental status, what medications they're on. And then finally, the extent of the surgery. Is it simple or is it radical? So we're going to talk about each of these separately for a minute so you can understand the purpose and reason for the type of surgery. So let's talk about the purpose, first of all. When we talk about the type of surgery concerning purpose, we talk about diagnostic. It allows us to confirm or establish a diagnosis. So say I come in and I have terrible abdominal pain, and they've tried everything. They did an ultrasound, they did a CAT scan, and I'm still having this pain. They might go in and do diagnostic surgery. They might do what we call laparotomy. So they go in there and they look to see what is causing this pain because all the tests have been negative. They can do corrective surgery where they do excision or removal of a diseased body part. So say I have a benign bone tumor, and that benign bone tumor is causing me some pain or is interfering with my range of motion. So they go in there and excise that benign bone tumor. They can do reconstructive surgery where they actually restore function or appearance to traumatized or malfunctioning tissues. So say I had a right mastectomy following breast cancer. They can go in and use my sternocleidomastoid muscle to actually pull it up or use part of my chest muscle and do that to create a breast. And so that's reconstructive surgery. Then there's ablative surgery where it removes a diseased body part. So say I get a wedge resection because part of my lung tissue is damaged from maybe lung cancer or some kind of work-related injury. Then there's palliative. That relieves or reduces pain or symptoms of a disease, but it's not a cure. So say I'm dying of lung cancer and I have a tumor pressing on my lung that's interfering with my breathing. They can go in and remove that tumor so I can breathe better. It's not going to cure me or make me last longer, but perhaps it'll make my quality of life a little bit better that I have left. Then they can do transplant surgery, and that's to replace a malfunctioning structure. Sometimes when they do transplant surgery, like when they do a kidney transplant, they leave the previous kidney in there and put a new kidney in there as well. And then they can do cosmetic surgery. Say I had a broken nose, and they perform that rhinoplasty to improve my personal appearance. Then there's the urgency for types of surgery. We think about it in this way: emergency, elective, urgent, and required. Now, emergency surgery means we have to get them to the operating theater now to preserve function or the life of the client. So say I was in a motor vehicle accident and I have abdominal bleeding. That means I have to go to the OR now or I'm going to die. Elective surgery is performed when surgical intervention is the preferred treatment. So say I have osteoarthritis of my knee. I'm electing to get a new knee because the pain is so severe it's interfering with my walking. Then there's urgent surgery. It's necessary for the client's health to prevent additional problems, but not necessarily emergent. So think about this. I have bladder cancer and I have a bladder tumor, so I need to go in and do a urinary diversion. It's urgent. I need that done. However, it's not emergent. It's not life-threatening. I don't need that surgery to preserve function. And the reason we have to know about the urgency of surgery is when we schedule the surgeries, because we might have an emergency surgery come in. So what surgeries can we then cancel to another date? Now, I know patients get frustrated when surgeries get canceled, but we can do only so many surgeries in a day. And when we do that, oftentimes if we have an emergent surgery, like somebody comes in after a motor vehicle accident and has a traumatic amputation, then we have to find time to do that surgery. So then elective surgeries and required surgeries could be put on hold. Now, if we have a lot of emergent surgeries, say in the event of a disaster or something, then even urgent surgeries may have to wait a day or so. And then there's required surgery. It has to be performed at some point, but it can be scheduled. So that could be like possibly like a tonsillectomy. I'm having really swollen tonsils that are so infected and they're worried about the strep infection not going away. So it's required. Or I have mitral valve prolapse and I need a new valve, but that can be scheduled. So you have to understand the purpose of the surgery and the urgency. All right, so let's talk about surgery consent. Every client that's going to surgery must sign a consent form. And before they sign that consent form, the physician has to come in and has to explain the surgery. He not only explains the surgery, but he explains the possible risks and complications, and then he explains, what other options are available and, all those things before the individual signs that consent form. That is not your job. You cannot get a consent signed. You can be the witness of a consent form, but if a consent is not signed, you have to notify the physician because he's the one that has to explain the surgery. So if an adult client is confused, unconscious, or not mentally competent, a family member or guardian must sign that consent form. Now, persons younger than 18 that live away from home, like say you're going to UTEC and your family lives in Kingston, and you live away from home and you're regarded as an emancipated minor, then you can sign your own consent form. But if you're 18 and still living with your parent or guardian, if you're under 18 and still living with your parent or guardian, then they must sign the consent form for you. Now, in an emergency situation, the surgeon may have to operate without consent. So say I am riding my motorcycle down the road and I wreck. And so they come onto the scene and realize I have to be sent to surgery now. I have no identification, they can't notify my family, or even if I have identification, they couldn't get in touch with my family, and if I don't have surgery now, I'm going to die. The surgeon has to take me into surgery because that is just how it has to be done because it's an emergency surgery and we're not going to wait for consent. Clients must sign the consent form before receiving any preoperative sedatives. So if they had any kind of pain medication or something that makes them drowsy, we can't let them sign the consent form. So when the client or designated person has signed the permit and the adult witnesses all sign, an adult witnesses and also signs it, like we can be the witness, indicates the client is signed voluntarily. So that way you can't, if you witness it, then you saw that patient or know that patient wasn't coerced into having surgery. And also, you can back out of that at any time. So I can be in the OR waiting room, waiting to go into surgery, and then decide to change my mind, and you can't give me surgery. So even though I can sign that consent, I can still back out of it any time. I still have the right to choose whether I want that surgery or not. So the nurse is actually responsible for ensuring that all necessary parties have signed the consent form and that it is in the client's docket before the client goes to the operating room. So you can't send somebody in there if the consent isn't signed because they need to check that. So everything has to be on the docket. So we're actually going to talk about a preoperative checklist to ensure that we have everything there. So 3 conditions must be met for the consent to be valid also. So I want to just talk about these 3 things so you're aware when you witness a consent. First, information must include adequate disclosure of the diagnosis. So actually the physician had to come in and say why they're doing the procedure, the probability of a successful outcome, the availability of benefits and the risk and alternative treatments and all that. He has to explain all that. Then second, the patient must demonstrate clear understanding. So they can't be under the influence of medication, or they can't be mentally incapable or actively psychotic, any of those kind of things. And third, the recipient care must give consent voluntarily. You can't be coerced in doing so or, strong-handed into doing so. So you have to do it voluntarily. All right. So it says the nature and intent of the surgery, the name and qualifications of the person performing the surgery, the risk, the chances of success, possible alternative measures, and then we have the right to refuse as well. So in the preoperative phase is when we do a lot of teaching. We can teach clients about their surgical procedure. So after the doctor explained it, you can go in and say, what questions do you have for me? Do you need anything explained? And then expectations is best done during that preoperative period. So any expectations they have, like do they think that they're going to go home today? Find out what they think, because if they're going to be admitted to that medical surgical ward, you need to let them know that. And if you involve the family members, it's better for them because then they can participate in that recovery, because they're going to be the ones doing the wound dressing change, or they're going to be visiting the patient, and they need to know also that there's going to be an NG tube in place or something like that. So in preoperative teaching, we should talk about preoperative meds. Oftentimes we have to give medications prior to there, like prophylactic antibiotics or antiemetics. So you should talk to the patient about the preoperative medications that will be given. Postoperative pain control. Let them know that they're probably going to have pain at the site, once the anesthesia wears off, and what they're going to have ordered for pain med if if not, tell them teach them about the pain scale and how to ask for pain med, and description of the post-anesthesia recovery room, what it's going to be like, and, so they're not scared when they wake up and they see all this oxygen equipment in an bamboo bag and they think something terrible happened. And then frequency of assessing vitals and use of monitoring equipment. If they're going to be on an ECG, or they're going to have an IV pump, or they're going to have oxygen or NG tube, explain that to them. And then teach them the deep breathing and coughing exercises and use of an incentive spirometer, and explain to them it's so they don't have atelectasis. And maybe not use the term atelectasis, but tell them that those small little air sacs in their lungs can actually collapse if they don't deep breathe. And then if they're having abdominal surgery or surgery where it's going to cause pain for them to breathe in deep, we want to teach them how to splint the incision for breathing and exercise and moving. And then do the pedal pumps and the leg exercises. And if they're going to be on antithrombolytic therapy afterwards, or if they're going to have like antithrombolytic hose or sequential compression devices, you should share all that information with them. What kind of IV fluids are they going to have any? Are they going to have any drains, do you think? You might not know this information, but if there's a possibility, like if you know that certain patients after a mastectomy have JP drains in, then to explain to them, you may see a drain and it'll have a little bit of red drainage. That's not, uncommon. Some people have that, some people don't. Let them know what to expect. That way they're not so nervous when they come out of their anesthesia and they're in the recovery with all these tubes and wires all around. So when we do the preoperative history taking, it's very, very important. We want to know their current health status because that allows us to evaluate the risk for the patient. Are they obese? Are they diabetic? Slow wound healing, we know that. What's their nutritional status? Because that involves, maybe low protein. What's their labs? What was their CBC? What's their H&H? What's their platelet count? All these things are important so we know what risk factors they have. What allergies do they have? Verify their allergies. I don't care if it's on the chart or the docket or not. You still want to verify those allergies. Sometimes they forget them. Sometimes they write them wrong. You want to know the allergies and what they experience with that allergy. What medications are they on? When did they stop taking them? Aspirin and clopidogrel need to be taken stop taking at least 7 days before that surgery. Any previous surgeries, did they have reaction to anesthesia? That's important because then they're at risk for malignant hypothermia. Did any of their family members have problems with anesthesia? Because that also is a big red flag that they might have risk for malignant hypothermia. Understanding the surgical procedure and anesthesia, do they know what to expect? Do they know what they're having done? Smoking, that puts them at risk for, breathing difficulties or even atelectasis afterwards. Alcohol is very important. We need to know how much they drink because they can go into DTs afterwards. So we might have to make sure that we give them alcohol. And believe me, I've given patients alcohol after surgery to prevent DTs, just to prevent things like increased intracranial pressure or risk for bleeding and things like that. Their ability to cope and their coping mechanisms, their resources, and any cultural considerations should be considered in there as well. And their nursing diagnosis, I think you can think of these: acute pain, nausea, ineffective thermoregulation. It's very cold in the OR. That coldness keeps down that bioburden. That's why we keep it so cold in there. We don't want that bacteria to grow, but then also it sometimes can cause ineffective thermoregulation for the patient. So these are just some of the preoperative surgical nursing diagnoses that you should be alert for, that we want to be looking for post-op to help with these, because we know they could arise. We want to actually look at these needs and see if we can meet these needs so they don't become an issue for the patient. And then the day of surgery, we want them not to bring any valuables. Please don't bring anything. We tell them not even to wear their wedding ring because sometimes they can put tape over it, but if you're having surgery on your arm or something close to that, that's a fire hazard, and you're going to find out how we have to do fire risk assessments on patients getting surgery. So if you have piercings, we're going to take them out. So please, we tell them, leave all your jewelry or valuables at home. Dentures and contacts and prostheses can be removed. Have your family member bring them in after the surgery. Or, if they have to be there, we can put them somewhere safe if you don't have somebody coming in with you. And identification and allergy bands should be on that patient. And if they're typed and crossed for blood, they should also have a blood band on. So the day of surgery, they're going to be in the hospital gown. We don't want them to have their underwear on. You know, some people want to wear their underwear and we tell them they can't wear their underwear. You know, patients should not wear any cosmetics because it's going to actually interfere with our ability to look at their skin tone. Nail polish interferes with the pulse ox. So we really don't want them wearing any cosmetics the day of the surgery, and we explain that to them. But if you explain to why they can't wear the cosmetics, that's important for them because then they can recognize why they shouldn't do it, and they might be more compliant with therapy if you explain it to them. And then, of course, the legal preparation. Make sure there's an informed consent. Is there a consent for blood transfusion? Do they have an advance directive or DNR? And do they have a power of attorney? All that should be on the docket if that is possible. Then we do a physical assessment. We look at every single system. So we assess the cardiovascular system and did they have an EKG. We assess the respiratory system. Are they smokers? And what do their lungs sound like preoperatively? What is the renal system like? Are they having any blood in the urine? Did they do a UACNS? Did they do a BUN and creatinine? You know, when was their last void? The neurological system, what is their level of consciousness before so we can have a baseline? You know, we want that GCS beforehand so we can compare the preoperative to the postoperative GCS. And then musculoskeletal system, do they have any limitations or pain or, you know, any contractions or anything that could interfere with us actually positioning the patients appropriately, and should they not be in positions for long periods of time? In certain surgeries, they're in terrible positions for long periods of time, and we can't put pressure on certain areas for patients, so we need to know that. And we talked about the nutritional status and what's their albumin level and things like that. And then gerontological considerations. They don't always present with the same symptoms. They have healing difficulties. They might have weaker skin, so they're more prone to pressure ulcers. They don't react to anesthesia as well. It takes them longer to clear because they have decreased GFR. So you have to understand all these things. So we're going to go through each of the systems of the body, and we're going to identify these risks and document the baseline findings so we can compare those preoperative with those postoperative. Okay, so when we do this, we're doing that general survey. So we're looking at gestures and body movements, and you know how to do a general survey. Do they look fatigued? Do they look tired? You know, the cardiovascular system, we're looking at, you know, the heart rate and any heart abnormalities and what the EKG reading was, because alterations in cardiac status are responsible for as many as 30% of perioperative deaths. So that's a very big number to me. So I think that's very important that we assess that cardiovascular system very thoroughly. And then the respiratory system, because a decline in ventilatory function can affect breathing pattern and chest excursion, and it needs to be identified early. And then we talked about the renal system and also fluid and electrolyte imbalances. Did they do a complete metabolic panel? And what was the potassium before and sodium and magnesium? You know, and the decreased excretion of perioperative medications and anesthetic agents can build up in the body, and we have to know that. And then, of course, we talked about the level of consciousness and any deformities in the musculoskeletal system. And then gastrointestinal system. Any alteration in function after surgery may result in decreased or absent bowel sounds and distension. So they might need an antiemetic or an H2 antagonist to cut down the acid so there's no risk for aspiration when they're underneath anesthesia or post-op. And then the head and neck, the condition of oral mucous membranes. You know, we want to know that if they have any neck abnormalities, you know, that could be harmed when we position them, and also their hydration status. And then nutritional status. We need to provide extra padding to underweight patients. So if we have a gerontological patient with a fracture that already has poor skin, we need to pad that area if they're going to go back in and do an ORIF or something. And we don't want to create a pressure ulcer on these individuals. They may need protein and vitamins. And, you know, we need to maybe give them increased vitamin C and zinc for wound healing. And we really want to identify their dietary habits. Okay, and obesity, I told you obesity causes decrease. They have slower wound healing, slower recovery from surgery, puts them more at risk also for cardiac and pulmonary problems and for dehydration. And if the nutritional problem is severe, surgery may even be postponed. So that's why they do an albumin and a pre-albumin, and they look at like vitamin vitamins and, in their diet, and are they deficient in any like B12 or anything. Then the immune system. Patients with a history of compromised immune system or use of immunosuppressive drugs like methotrexate or cytotoxin for rheumatoid arthritis or lupus, that really puts them at risk for delayed wound healing, increased risk for infection. So if we know this beforehand, we can put things in place to make sure that we're identifying the factors that predispose this patient. Like corticosteroid use, maybe they use it for COPD, if they have an active infection. And oftentimes, if that surgery is not urgent or emergent, they'll actually cancel the surgery until they don't have an active infection. And then patients with active chronic infections like Hep C or B or HIV and tuberculosis may have surgery if it's indicated, but we might not use general anesthesia. We have to watch, especially with Hep B and C, about how the liver is going to tolerate some of these medications that we give. So you have to remember to put all these things in place when we are actually in the preoperative period. And then patients with diabetes are really at risk. They're the ones that have the slow wound healing and they're increased risk for infection, and surgery puts them at risk for ketoacidosis, and it's hard sometimes to regulate the blood sugars with their NPO, and it's hard to give them fluids sometimes because their kidneys have involvement. So they really are a very difficult branch of patients to have in the OT, and you got to understand how many diabetics we have, and a lot of times they're the ones going in for amputations and those kind of surgeries. So we really have to look at the people with diabetes and know they're at a risk and really assess them thoroughly. And then we talked about the musculoskeletal system and identify joints affected with arthritis and positioning problems. And then preoperatively, the patient may have to do skin prep at home before the surgery, and we give them ChloraPrep or something to use at home so they can cleanse the area the night before they have to get a bath. And then when they come in, we'll actually prep the skin after we drape them and do everything and create that sterile environment. And then elimination, they have to pee before, and then they have a certain time that they have to not take in foods or fluids, and they can actually have a surgery that's canceled if they've taken in foods or fluids within that 6 hours of surgery. And then psychosocial prep, just dealing with their ability to cope and how anxious they are because of the surgery. So we want them to definitely avoid before surgery. It prevents that involuntary elimination under anesthesia. It prevents urinary stasis that could lead to bladder infections. And also, it helps to prevent problems if they're doing surgeries with bladder distension and things like that. And some of the medications we give actually cause urinary retention, and some of the anesthesia causes it. So we don't want a bladder that is full of urine going into the surgery into the operating theater. And anesthesiologists frequently order preoperative meds. We order anticholinergics because they dry up secretion. So we might have a scopolamine patch behind the ear. We might have atropine drops. There's something to drop those secretions so there's no risk of them interfering and choking or aspirating on those secretions. And then anti-anxiety drugs, they just help relax the patient, and sometimes they need less anesthesia with those. As histamine 2 receptor antagonists, we talked about reducing that gastric acid so there's no risk of that actually coming back up and causing a risk for aspiration. And then they might be given narcotics, sedatives, or tranquilizers to be adjuncts to the actual anesthesia that they're given. Benzodiazepines are used for sedative and amnesic properties, and we talked about the anticholinergics, and sometimes opioids are given to decrease pain and intraoperative anesthetic requirements, and sometimes antiemetics are given. Just especially if you say, after surgery, oftentimes from the anesthesia, I have problems with nausea and vomiting, they might give you an antiemetic to help with that. And then antibiotics may be given to decrease the risk of endocarditis. So patients that have a history of valve disorders or a history of any kind of endocarditis or any problems there, they might, remember we had talked about in adult nursing one how endocarditis can result from colonoscopies and bacteria gets in the blood and goes to the heart and those kind of things. So if we give a preoperative antibiotic, we can prevent these things from happening. And so we want to make sure that if one is ordered that we give that and administer it appropriately. And of course, they'll be ordered intravenously because they're NPO. So we want to do a thorough assessment. Also, the meds, the allergies, the last time they ate, their dentures, make sure they're not in. Any loose teeth as well. I should put that on there as well because, the anesthesiologist really needs to know if they have any loose dentition because actually when they intubate that person, that tooth could actually become dislodged. So we need to know that. Any meds that they are supposed to give before, their IV, do you need to start one? We usually put an IV in, but do we need to have fluids running through that IV? And that just preoperative prep, and then we send the docket with the patient. So here's a sample of a preoperative checklist. I think it's important to have a preoperative checklist because it helps you to remember everything and you can't forget anything. So to ask you, is the allergy band on? Did you start the IV? Are there fluids running? What time was it started? What kind of fluids? Do they have a catheter on? Do they have a condom cath? When is it placed? Did they have clear liquid breakfast or have they been NPO since a certain time? So go through this preoperative checklist. And the reason I put it on here is so when you go to OT, take this with you. And that way you can see when that patient comes in, do they have a preoperative checklist and what does it look like and compare it to this and make sure that all those components are on there. And then they might have to do screening tests. We do routine tests like a CBC. It tells us our H&H, so it's a low beforehand because they might have bleeding. And so do we need to type and cross for blood? That's important. Their electrolytes. We want to make sure we know that potassium, that sodium, and that magnesium, especially in calcium. That fasting blood glucose and the BUN and creatinine, what's their kidney function, their ALT and AST, those liver function tests. Their bilirubin, the serum albumin for nutritional status, the total protein for wound healing, and to ensure we're going to have enough colloid pressure not to, have edema result. A urinalysis to see if there's any infection in EKG. All these tests should be on that docket prior to going to surgery. They may have to also have a chest X-ray. They may order that as well, and any other test that the surgeon feels that necessary, like they're going to do a platelet count to see if they're at risk for bleeding. They might do a bleeding time. Those kind of exams might be done as well. Now, the patient's going to be transported to the OR on the stretcher. We give an SBAR report. I'm not telling you have to use SBAR. There's another one I'm going to show you as well. It's called PACER. I don't care what you use to give the report, but it has to be a detailed report. If you use the SBAR, it's a nice handoff process. It gives you the situation, the patient's name, age, surgical procedure, surgeon, surgical site, all that. Then the background, significant patient history, allergies, medications, assessment, baseline vitals, baseline level of consciousness, findings relative to the surgical procedure, coping strategies, and finally recommendations like preoperative care still needed, such as IV antibiotics or, any of those kind of things. A post-operatively, he's going to need his dentures or his glasses or his hearing aids, those kind of things. That is important. A PACER handoff is similar to the SBAR, but it's a PACER, so it's patient problem assessment, continuing changes, and then evaluations and recommendations or other. So whatever you use, you need to get used to putting your information organized and in a manner that you don't forget anything in that handoff report. Handoff report is so important when we're sending a patient from surgery to the operating room because we need a thorough handoff report from preoperative to intraoperative and then from intraoperative to post-op and then from post-op to discharge, whether they're discharged on the medical ward or they're discharged home. So we need to learn how to give this detailed report. And if you use either the SBAR or the PACER, oftentimes you'll have all those components that you need in order to give a detailed, thorough report. All right, so I want to talk about the surgical team. It involves the anesthesiologist. There may be an anesthetist as well, like there could be a nurse anesthetist in there or, even a student in there, but oftentimes the nurse anesthetist can handle some cases on her own as well. Then the surgeon and the surgical assistant. a scrub nurse, and a circulating nurse. There can be other individuals in there as well, or less. You don't always need a surgical assistant if you have the scrub nurse. It depends on what kind of case it is, how involved it is, and how many people you actually need in there. Okay, so I want to watch 2 of these videos before we begin with the intraoperative area. This is the first one.
Surgical scrub up and gowning, a step-by-step guide. The purpose of the surgical hand antisepsis is to remove or destroy transient microorganisms and inhibit the growth of resident microorganisms.
Hi, I'm Jonathan. I'm the new junior doctor. I've been asked to scrub up, but I've never done it before. Could you show me how?
Certainly can, come this way.
Thank you.
Preparation. When preparing to scrub up, ensure that you wear appropriate attire and make sure this is as comfortable as possible. This includes clothes, hat, masks and eye protection. Jewellery such as bracelets, watches and rings are to be removed, other than plain band wedding rings, which can remain in place. Nail varnish and false nails are also to be removed beforehand, and nails should be kept short. Any skin abrasions to hands and arms must be covered with a waterproof dressing. Select an appropriate gown pack, checking integrity of the package and expiry date. Peel open outer wrap of gown pack, leaving green layer untouched. Select appropriate gloves and place nearby, ready to be opened by the circulator. Surgical scrub. Set the water to a suitable temperature and flow and open a nail brush packet.
Okay, so we'll start washing our hands now.
Throughout this process, the hands must be kept upright and bent at the elbows, allowing water to drain away, clean to dirty. Wet hands and arms thoroughly. Apply approximately 5 ml of aqueous scrub, for example Hibi scrub or Viodine, to the hands, using your elbow to release it from the dispenser. A hypoallergenic alternative is also available. The first wash should take about 2 minutes and includes washing the fingers, hands and elbows, arms up to the elbow. To be effective, the aqueous scrub needs a minimum of 2 minutes contact time with the skin. With fingers interlaced, work palm to palm. Place right palm on the back of left hand with fingers interlaced. Repeat on the other side. Rotational rubbing backwards and forwards with clasped fingers of right hand into left palm and vice versa. Rotational rubbing of right thumb clasped in left hand and vice versa. Rubbing fingertips on the palms of both hands. Continue with rotating action down opposing arms, working to just below the elbows. Rinse thoroughly, keeping hands above the elbows so the water always drains from hands to elbow. Take hold of the nail brush and apply surgical solution, approximately 5 ml again. Brush both right and left nails, but only the nails, not the fingers, palms or hands, as this can cause skin damage. This must last about 1 minute. The nails only need to be scrubbed on the first surgical scrub of the session. Any more often can lead to skin damage and colonisation. Again, rinse thoroughly, leaving hands higher than elbows. The last wash repeats the first, but this time only goes as far as the wrists to avoid compromising the cleanliness of the hands, and should last approximately 1 minute. Again, thoroughly rinse hands and arms and turn the taps off with your elbows. Let excess water drip away. Do not shake. Keep hands higher than elbows. The whole process should take about 4 minutes. Gowning up. Moving over to the gowning trolley, open the green inner pack, ensuring you open away from your body first. Carefully, fully open a hand towel. Dry your hands by placing the towel in one hand and blotting the skin, drying on the opposite hand. Always start at the fingertips and work down towards the elbows using a corkscrew movement, and then discard the towel. Never go back up the arm towards the hand with the towel. Repeat on the other side, ensuring hands are completely dry. Gowning is achieved by using the closed gloving technique. Pick up the gown and identify the neck area, then step away from the trolley. Using your thumbs and first fingers, pinch the top of the gown and let it fall. Do not shake. Ensure it doesn't touch anything. Unfold the gown and identify where the arms are to be placed and do so. Keep hands inside the gown. A circulator will now tie the gown at the back. Keep arms above waist level. With hands inside the gown cuffs, pick up the gloves in its inner sterile wrapper and then turn them upside down so the right is on the left side and the left is on the right side. With your right hand, place your thumb under the fold of the right glove, then flip the glove over onto the palm of your covered hand. With your left hand, grab the fold on top and pull up and over your hand. Next, pull gown and glove up your arm so that the fingers are in the correct position. Repeat this process with the other hand. The gloves must cover the cuff of the gown as this is not waterproof. Ensure gloves feel comfortable and fit snugly. Take hold of the gown pass card and pull the left hand tie out of the card, keeping hold of it. Pass the card to the circulator, being careful not to pull the remaining tie out of the card. Next, rotate 360 degrees anti-clockwise and pull the tie out of the card held by the circulator. Now secure both ties in a bow at the side. You are now sterile around your front and back. Keep your hands away from your face and above waist level. You are now ready to enter the sterile field. Once in the sterile field, hands should be kept at chest level at the front. Do not cross hands or put them under the axilla. When you pass another person who is scrubbed, try always to pass back to back.
One more I want you to watch that I think is very important.
Hello everybody, I am Mike from Surge Tech Academy, and today I'm going to demonstrate the steps for gowning and gloving another person. Now, most often I would have my goggles and my mask on, but for today, education purposes, I'm gonna have those off. Now, usually the person that's gonna come into the room is a surgeon, but it can be another scrub tech, can be a nurse, can be a resident, whoever. At this point, I've already gowned and gloved myself, and my field and myself are sterile. So first, the person walks into the room and I have to present the towel to them. Now, I know how much I hate those white paper towels, so I always give my surgeon a cloth towel. So on the short edge of the towel, I create a cuff and I place the towel into the surgeon's right hand. Now, while they are drying their hands, I don't have to watch them do that. I can go on to the next step, and I'm gonna go ahead and grab the gown. Now, couple of things. I always present the gown pointing towards the surgeon. I extend the gown all the way to the floor, making sure I don't touch anything unsterile. I like to grab the very side edges of the gown. Now, there are a couple ways we can cuff our hands. I like to do this little twirly action, so that way my fingers are completely cuffed. Some people just grab the gown and put on. It's really up to you. The key is you want to make sure all your fingers are covered. So after I've made a good cuff, the armholes are open, the surgeon's gonna walk in, and I'm gonna drop the gown right about the ears. Now, the key to this is I have a good cuff with my gloves going in, but coming out, they're open. So if I extend too far and I come back, the risk is that I could touch the bonnet or their goggles. So I always tell my students, drop at the ears. After I've dropped the gown, I'm gonna expose the hands. Again, sometimes the surgeon is going to take care of this on their own. Sometimes the circulator will pull on the gown. But again, we're going to expose the hands. Next, we're going to grab the glove. I tell my students always to do the right glove first. Now, there's a couple techniques we can use when we glove the surgeon. So I think the best way is to completely cover our hands. And how we do that is we invert the very edge of the glove. So I'm gonna go ahead and invert the very edge and put my thumbs underneath. Now the key is I wanna get a perfect circle for the surgeon to put their hand in. So palm is facing towards the surgeon, the writing is facing towards the surgeon, and I'm gonna present the glove to them and the surgeon's gonna put it in. Awesome. Now the left glove is a lot easier, all right? I just extend the glove completely, the palm and the writing are facing the surgeon, all right? I just extend the glove. Now this is where I use the second method of gloving. Here my thumbs are out. They're not protected, but it's pretty hard to get them contaminated. So you can either completely cover your fingers or just have your thumbs out. The surgeon's gonna grab the glove and extend it to that perfect circle and put their hand in. Awesome. So at this point, the surgeon's gonna grab the tie. I'm gonna grab the green part. The surgeon's gonna turn and pull and tie. And there we have it. We just gowned and gloved another team member. So until next time, I want you to have a great day in surgery.
So I wanted you to see that as well, because I think that's important for you to see before we start talking about it, because you're going to have to learn to do that and we'll actually demonstrate it in the lab when we're working. Okay, so intraoperative. We know the surgeon is responsible for determining the preoperative diagnosis and the choice and the execution of the surgical procedure. That's pretty obvious. Let's talk about the scrub nurse. Now, the scrub nurse can be an RN or can be a scrub tech or can be an enrolled nurse. In the States, we use a lot of our enrolled nurses as scrub nurses, or we do have scrub techs as well. But any of the ways, whether it's an RN, scrub tech, or enrolled nurse, they do the preparation of supplies and equipment on the sterile field, maintenance of patient safety and integrity, and observation of that scrub team for breaks. If they notice a break in the sterile field, whether it be the surgeon or another team member, they must tell them that there was a break in the field and that we have to stop and either re-glove the hand or whatever we have to do. Okay, so they also have the provision of appropriate sterile instrumentation, so they set up and make sure we have all the instruments, the sutures and supplies we need, and they do the sharps count. Then the circulating nurse. The circulating nurse must be an RN. They're responsible for creating a safe environment, managing the activities outside the sterile field. So if they collect a specimen, it needs to go to the lab. If they need to collect blood, if they need to look for a diagnostic test or talk to the family, whatever they need to do, they're managing those activities outside that sterile field. They're providing nursing care to the patient, but they're documenting intraoperative nursing care and ensuring surgical specimens are identified and that they're in the right media, whether they go on a slide or however they have to do it. They're in charge of the instrument and sharps count and communicating relevant information to individuals outside of the OR, such as family members or whatnot. All right, so you can see the perioperative nurse, the instrument nurse or scrub nurse, and the circulating nurse and the roles. So I put this on here so you can take this with you as well when you go to the OT. I think it's very good, and you're going to hear me all the way from first year to fourth year telling you to have clinical notebooks that you take with you. I think it's very important. This helps you identify the roles of the individuals and you can take notes. That's how you learn. And then you can go back and look at those notes. So I know that preoperative nurse may be an RN or an EN, most likely an RN, but it prepares the room with surgical team, ensuring all requirements for the surgical procedure are available, serves as a patient advocate throughout that surgical experience, and maintains patient safety, privacy, and dignity, and confidentiality, of course. And then the scrub nurse follows designated scrub procedure, gown and glove and sterile attire, remains in the sterile field, and assists the surgeon. Then that circulating nurse is not scrubbed, gowned, or gloved. Remember that, because they're in and out of that surgical field. They remain in the unsterile field. They document care. They might have to go get medications, those kind of things. So the anesthesiologists or anesthetists anesthetize the patient. They provide the appropriate levels of pain relief, monitoring the patient's physiological status, their respiratory status. They have to make sure that that patient's out during that procedure if it's general anesthesia, or that the limb or whatever is actually prepared for surgery and there's no feeling in that limb if they're going to do the surgery. So the anesthetist is more about providing that pain relief and monitoring the patient during that anesthesia process. But so the surgical team, the nursing roles are staff education, client and family teaching, support and reassurance, advocacy, control of the environment, provision of resources, maintenance of asepsis, and monitoring of physiological and psychological status. So that's our role for being part of that surgical team. So it's a little bit different than any other area in that hospital. So you have to recognize that. Okay, so we talked about surgical scrub, gowning, and gloving. So I had you watch those videos and then we'll practice that. But it is a skill that you have to continuously practice. So when you go to the OT, if they have you scrub in, you have to recognize that you're going to have to practice that skill. Now, I want to talk a little bit about anesthesia. So anesthetic techniques and agents are selected by that anesthetist, okay? And what they decide when they select it is physical and mental condition of the patient. So if they have severe COPD, we probably won't use general anesthesia if we don't have to. Maybe we can use an epidural anesthesia or something like that. And then they look at allergy and pain history, expertise of the anesthetist, and factors related to the operative procedure. And so they also look, did the patient have any kind of reaction to anesthesia? What was the anesthetic agent that they used? Those kind of things. So there's procedural sedation, and that may be deep sedation or conscious sedation. It's used for diagnostic or therapeutic procedures and includes varying levels of sedation, analgesia, and anxiolytics. Deep sedation must be administered by anesthetist. Then there's conscious sedation. And so that's for procedures usually performed outside the OR, like maybe a colonoscopy or an endoscopy. And that doesn't really require an anesthetist to do that. Now let's talk about the different kinds of anesthesia for a moment. And I put this in a chart as well. The reason I put it in a chart is so you can take it with you in your clinical notebook so you have it with you. We're going to talk about general anesthesia, regional anesthesia, and local anesthesia. Now, there's two types of general anesthesia. There's total IV anesthesia that they call TIVA, and then there's inhalation anesthesia. So techniques of choice for surgeries with significant duration or that require relaxation, uncomfortable position, control of ventilation, balance technique with adjunctive drugs. So general anesthesia is going to be when we need you to go to sleep. We don't want you to wake up. We don't want you to feel anything. We don't want you to be able to talk or move or do anything. So general anesthesia is best if it's going to be in a position for a long period of time. The surgery is going to take a while and you need intubated. All right, regional anesthesia. It's always injected. It may be peripheral, like through the brachial plexus, or block, or central through epidural block. Okay, so it can be either way. So if we're doing peripheral, say we're doing something with the lower leg or foot, we can use peripheral through that brachial plexus. But if it's central, then that epidural block, then we may need it a little bit more. So you get loss of sensation in body region without loss of consciousness. So when specific nerve or group of nerves is blocked. So we can still give you an anti-anxiolytic or something to control that, but you won't be out. You're not going to need intubation, okay? So we won't have that risk there of the things of general anesthesia like respiratory status and things like that. But believe me, regional anesthesia comes with its own problems like hypotension and urinary retention, so we'll talk about that. Then there's local anesthesia, and that can be topical, ophthalmic, like if we're doing eye surgery, nebulized, or injectable. So general anesthesia acts on that central nervous system. You get that loss of sensation, reflexes, and consciousness. So it can actually be administered IV, IM, inhaled, or through the rectum, actually. There's 4 stages. There's induction, the airway secured by an endotracheal tube, because remember, so we got to control that breathing. Then the excitement, that quick and smooth administration of anesthesia. okay? Then surgical anesthesia, the client's unconscious, then medullary depression. And we don't want to get there because too much anesthesia can lead to death. So we don't want that like that, okay? We don't want to get too much anesthesia. So we just want that induction, the excitement, then the surgical anesthesia, and hopefully they're monitoring so we don't get, that death. So there are the 4 stages: analgesia, sedation, and relaxation, then excitement and delirium. Okay, some patients might start talking, saying silly stuff as they go out. Okay, then operative anesthesia, surgical anesthesia, and stage 4 is danger, emergence. Okay, then we have to recover them from anesthesia. So we don't want to get to that medullary compromise. Okay, but the anesthesiologist or anesthetist is aware of that, and they're constantly monitoring the patient. Because complications can be overdose, like we just talked about, hypoventilation, okay, so they're constantly monitoring the respiratory rates and, all those things, and making sure that they're getting enough oxygen and all that. And then malignant hyperthermia, okay, that we'll talk about in a minute. And then just the complications of intubation. They can, harm the vocal cords, or it can cause inflammation, and, all those kind of things that can happen. Okay, then there's adjuncts to general anesthesia. These just help put the patient out, and maybe they require less anesthesia with these, but they help. Sometimes we give antiemetics because adjunct to general anesthesia, because then it helps to reduce nausea and vomiting after that anesthesia. We can give benzodiazepines because it's it's induction to amnesia and just causes some sedation, and then opioids do the same thing. But remember, with adjuncts such as opioids, it can also increase the respiratory depression. And then we can also give neuromuscular blocking agents. They facilitate endotracheal intubation, and they produce relaxation, paralysis of the skeletal muscles. So we give these, if we have to, intubate and it's going to be a tough intubation, or, any of those kind of things. So it interrupts the transmission of nerve impulses at the neuromuscular junction. Okay, so that patient can't move. All right, so it gives that total paralysis kind of. They have to be very closely observed for airway patency and adequacy of respiratory muscle movement. And lack of movement or poor return of reflexes and strength may indicate need for further reversal agents and even ventilatory support. So you have to be really careful when you give these neuromuscular blocking agents. Then we move on to regional anesthesia. It uses local anesthetics to block the conduction of nerve impulses in a specific region. So it may be given a sedative, they may be given a sedative. I told you, just something to help them either not remember, like Versed, or something to relax them, But there's no loss of consciousness. There can be some amnesia properties, but there's no loss of consciousness. And the patient experiences loss of sensation and decreased mobility to a specific anesthetized area. Kind of think of like an epidural kind of thing. So if you get an epidural for pregnancy, you can't feel anything, but you're still conscious. Okay, then a spinal, or they can have a Bayer block, which is intravenous. Then there's the nerve block, then there's local, and then there's topical. So all these can be a type of regional anesthetic, actually. So if you look, and this is the methods of administration, and so I put this here so you can differentiate the different regional anesthetics when you go to the OT. So take this chart, cut this off and take it with you. And there's topical, you apply 30 to 60 minutes before procedure, and it causes local infiltration and inject agent into tissues through which the incision will pass. So like this, it can be like your different ones that cause that whole area to be anesthetized, like Novocaine kind of thing. And then peripheral regional nerve block, inject agents into or around specific nerve or group of nerves peripherally. Then your central nerve block and your epidural block. So these are the different regional anesthetics that you may come into contact with in the OT. Now complications, of course, anaphylaxis, if there's an allergy or any of that kind of thing. Administration technique, if they, aren't really proficient in doing an epidural block, they can cause some spinal injury there, so we have to worry about that. There's always the risk of overdose, and then systemic absorption that can cause, different problems to happen, like hypotension and things. And spinal and epidural anesthesia, we have to really observe closely for signs of autonomic nervous system blockade. And so when we do that, we're going to have the bradycardia, the hypotension, nausea and vomiting. And it's really less likely to happen with epidural anesthesia, but I've seen it happen. So it can be spinal or epidural anesthesia. So we have to be alert of what their heart rate is, changes in those blood pressures when they change with getting up or, changing position, and then severe nausea and vomiting. So anesthetic drugs should be carefully titrated in our gerontological population. Okay, they have to be delivered slowly. They're increased risk of injury from tape, electrodes, and warming and cooling blankets, and they have osteoporosis and osteoarthritis. And also they're more prone to hypothermia. So there's a lot of gerontological considerations when we consider that older population. And I told you we have to identify these risk factors, and sometimes we have to ensure there's extra padding to protect, from injuries. We have to protect the skin. We might have to use paper tape. We might have to ensure we have warm blankets. We might have to position a different way or give them different anesthetics. So you have to be aware of the gerontological considerations when they're in the OT. In the operating room, the air is filtered and positive pressure is maintained to reduce those number of microbes. The temp is below 70 degrees. That helps. Like I said, the cooler it is, it retards that microbial growth. Then there's 3 areas. So there's the unrestricted area where street clothes are allowed. And when you go to Cornwall, I know they don't really have these areas, but outside the OR is the unrestricted area. Now, when we have our big ORs, we actually have these different designated areas, but you're going to know where the semi-restricted and restricted area is. So the semi-restricted zone is personnel are required to wear scrub clothes and caps. So like your circulating nurse is still going to wear the scrub clothes and caps, okay, but she's not going to be sterile in that restricted zone where the personnel are required to wear scrub clothes, caps, shoes, gowns, covers, masks, and do the surgical scrub that we just saw. So in that surgical suite, I made this for you as well as a table. There's the unrestricted, the semi-restricted, and the restricted area. So the unrestricted area is where they can wear the street clothes, okay? The holding area, locker rooms, there might be a nurse's desk at the front that you can enter. Like at Cornwall, or at SAS, I know there's the area you can go in. There's that nurse's desk there. That's the unrestricted area. Then there's the semi-restricted area. Peripheral support areas and corridors where only authorized staff are permitted. Staff must wear surgical attire and cover all head and facial hair. So you still got to have all that hair up in those things, but you are not scrubbed in. You can't be in that unrestricted area like the operating rooms where the scrub sink is, the sterile stock room, all of those kind of things. So I explained each of the unrestricted area, the semi-restricted area, and the restricted area. Now we should talk about operating positions. It depends on what procedure is being done, depending on what operating position they should be in. You can see a little bit of these different positions. If you look, there's the lithotomy position. Patients in lithotomy might have like hysterectomies or something like that. Then there's the Trendelenburg position, supine. So it depends on what procedure they're going to do, depends on how we have to position that patient. And then you have to think about what risk factors, what areas can be at risk for breakdown, what areas can be at risk for pressure sores or, just contractures or muscle problems or weakness, all those kind of things. So positioning of the patient depends on accessibility of the operative site. We did a hemorrhoidectomy, so that patient was in almost like a lithotomy position and did it that way. Now, some surgeons might do it a different way. So it just depends. Some surgeons will require certain positionings as well, but we want that accessibility of that operative site and administration and monitoring of anesthetic agents because the anesthetist needs to see that patient. They need to see the coloring of the patient. They need to see the respiration. They need to look at that patient. And of course, maintenance of the airway. We want to ensure that we position them in such a way that they're going to have maintenance of that airway. So we want to ensure correct skeletal alignment because we don't want to cause any problems just because of how they're positioned. And we have to think how long they're going to be in that position as well. We want to prevent pressure sores, any pressure on nerves, any pressures on the eyes, any of those kind of things. Sometimes when they're in that Trendelenburg position, that can put some pressure on the eyes as the blood flows, to the brain. So you have to recognize these things and then provide for adequate thoracic excursion too, because we have to ensure that they can breathe well. So we want to prevent occlusion of arteries and veins because we don't want to have any ischemia areas as well. We want to also think about modesty, provide modesty and exposure. We drape the patient. We want to ensure that we are as modest as possible. So we want to cover those areas to give them some dignity and recognize and respect needs such as pain or deformities, because we don't want to have them come out of surgery having more pain than when they went in because of how we position them. I also mentioned previously in this malignant hypothermia, and it occurs when body temperature, muscle metabolism, and heat production increase rapidly in response to stress and in some anesthetic agents. So we always ask the patient, did anybody in your family have problems with anesthesia? Because usually if one person in the family had problems, another person, you're really prone to having those problems. So we want to know that. And there's certain anesthetic agents that we know if that person exhibits any malignant hypothermia, they're more prone to do so with those certain anesthetic agents. So we don't want to use them in the patient. What will happen with malignant hypothermia is they'll get tachycardia, tachypnea, cyanosis, a really high fever, muscle rigidity, diaphoresis. Their skin will start to mottle. They get hypotensive, an irregular heart rate, no urine output, usually decreased, but it's almost no urine output. And they can eventually get cardiac arrest if we do not give them some kind of medication on board to help with a malignant hypothermia. So catastrophic events that can happen in the OR, malignant hypothermia, and then we did talk about anaphylactic reactions. Both of these occur because of anesthetic agents. Now, malignant hypothermia is quite rare, and so it usually manifests intraoperatively, but it can occur in that PACU. So you have to be aware, okay? You have to be aware that that patient may be at risk for malignant hypothermia. Plus, you have to know the signs and symptoms of malignant hypothermia. Usually it occurs with exposure to succinylcholine, but it can occur other times as well. So I don't want that to be the only thing, but it's usually when it does occur. Now, anaphylactic reactions manifested because the anesthesia really caused hypotension, tachycardia, bronchospasms, and the pulmonary edema. So even though these usually happen intraoperatively, they can happen in the PACU as well. Okay, and we talked about all the things that happen with malignant hypothermia. So you have to recognize these signs and symptoms so we can actually give them prompt administration of dantrolene. Okay, it slows the metabolism, reduces muscle contraction, mediates the catabolic processes. Okay, and to prevent it, it's important to know a history. You can prevent malignant hypothermia usually if you do a thorough history. Now, if nobody in the family had any kinds of problems and the patient's never had surgery, you may not be able to recognize that. I get it. But you should be alert for the signs and symptoms so we can get the dantrolene on board and give it to the patient so they don't go into cardiac arrest. So there's also another problem in the OR. We usually do a fire risk assessment. Surgical fires can be prevented. Care must be taken to correctly place the grounding pad and all electrosurgical equipment to prevent injury from burns and fire. Smoke particles produced during laser procedures can contain hydrocarbons like isopropyl and cyanide. These airborne contaminants can cause respiratory irritation, have mutagenic and carcinogenic potential as well. Smoke evacuators may be used to minimize this exposure, and you might see those, but you have to be aware. So you should ask when you go to the OT, what's your fire risk assessment? How do you complete the fire risk assessment? Have you had a fire in the OR? Do you do some kind of fire risk drill or anything? What do you do to prevent the fires in the OR? All members of the surgical team should do a timeout. Now, this timeout procedure is so very important, and we recognize this from having accidents occur. Because somebody goes in, maybe the nurse marked the right leg and the left leg was supposed to get amputated, and then they amputate the wrong leg. Or they had a patient come in, it was a busy day, and they took in the wrong patient and did the wrong surgery on the wrong patient. Now we know surgeries occur so often and all we hear is the bad stuff. I get that, okay? But in reality, we have to put things in place so we don't have these bad occurrences happening. So all members of the surgical team stop during the timeout, okay? They say timeout, and then they have things they go through. They verify the patient, they verify the surgical procedure, the surgical site, the anesthesiologist verifies, if there was any pre-op meds given. All those things are done. They might even say, like that was in that video that we watched, the fire risk assessment and everything. All that is in the timeout. Once they verify, then the procedure can go on. Okay? So the post-operative period now, because we did the pre-op, the intra-op, now we're at the end, we're at the post-op. It begins immediately after that surgery. Now, that's when complications can really occur. I know they can occur in the intraoperative as well, but PACU is where you really need to be observing that patient for complications. It should be located adjacent to the OR, so we minimize the transport and it provides immediate access to either a surgeon or an anesthetist or an anesthesiologist that can come in and intervene when we find things that are wrong. Okay, so our whole focus in that post-operative area, or PACU, post-anesthesia care unit, is protecting that patient and preventing complications from that surgical procedure. So it's airway, breathing, circulation. We're checking that airway. We're ensuring they're breathing adequately and checking for any hemorrhaging. So we're doing those vitals. We're using equipment such as carbon dioxide detectors and IV supplies and medications and pulse oximeter and suction equipment and EKGs. So there's a lot of equipment in that post-operative area. That's why it's important to prepare that patient, because they're going to see a lot of things. They might hear a lot of noises in there. We're doing continuous vitals sometimes, so we really have to prepare that patient because there's a lot of equipment in that post-anesthesia care unit. So when they get there, we have to do a report. Now I want to show you something very important, and I gave you a handout of it, and I want you to keep this and I want you to use it. It is the PACU handoff checklist, and it is so important. When you do your handoff report to that, from that OR to that PACU, you have to ensure that you give adequate information. And then when you go from PACU to the floor, you better give that same information. So they need to know the patient, the surgery, the allergies, the type of anesthesia. Very important. Did they get TIVA? Did they get inhaled? Did they get regional? Did they get spinal? That makes a difference, because it makes a difference on what we need to look for. We don't need to look for signs and symptoms of malignant hyperthermia if they didn't get TIVA. Okay, so it's important. Past medical history. Okay, their level of consciousness before, preoperatively. How much blood was lost? Did they get a Foley catheter? How much was their urine output? How much fluid went in? What medications were they given? When were they given pain meds? What are the new orders? You go down through and you learn this PACU handoff checklist, and this is what you're going to use. Now, I give it to you in a handout. I expect you to learn how to use this. You're going to need to know how to utilize that, because it's going to be so important when you're going from intraoperative to postoperative and then on to either discharge home. You won't have to do it, but if they're going to medical surgical floor or another facility. So when you give that PACU or PARU, I'm not sure what you guys call it. We call it PACU. So I've been trying to use PACU or PARU because I'm not sure what you guys call it. But the general information is the patient's name, age, surgeon, surgical procedure, presence of drains and urinary catheter. Are they in? Were they in? Did they catheter during whatever? Patient's history, indication for surgery, medical history, current medications, and allergies. Intraoperative management, anesthetic medications used, other medications received, blood loss, fluid replacement, including if they received any blood, urine output. Unexpected anesthetic events or reactions, unexpected surgical events, vital signs and trends, and results of intraoperative laboratory tests if they were done. Now, you might not have all this information, but for the most part, you're going to have it. So if there was 500 milliliters of blood loss, I need to know that. Okay? Because I need to monitor for any further blood loss and if there's any signs and symptoms of shortness of breath or need for an H&H, whatever. Airway patency. Was there an artificial airway? What was the respirations equality? Breath sound, supplemental oxygen used, and was there a continuous pulse ox, and what were they rated? Was there an ECG monitoring? Do I need to do it now? What were the vital signs? How often should I be doing vital signs? Peripheral pulses, capillary refill, and skin color and temperature. You are doing all these, and you want to know what they were in the OR to compare your results. So when they come to post-operative, you get that report, you do your immediate post-operative assessment and compare it to what it was pre-op and intraoperatively. So my very first thing is airway. What is it patent? Do they have an artificial airway in? Because sometimes, after surgery, they'll leave the airway into the patient's awake. If the patient's unconscious, you put them in the left lateral position. You know that's the rescue position. It goes in that position in case they vomit, any of those kind of things, but you put them in that position. After they wake up, then they can be in the semi-Fowlers or whatever, unless it was spinal surgery and you specifically have to keep them supine. You want to know their breathing. Right after you assess the airway, if it is patent and they have an artificial airway in and it's okay, then we go to breathing. What was the respiratory rate and quality? Breathing sound, supplemental oxygen, and should they be on continuous pulse ox? Oftentimes, in the PACU, our thing is continuous pulse ox for 15 minutes. If it continues to stay the same and there's no problem, we do the pulse ox every 15 minutes for 1 hour, then every half hour for another hour, then every hour after that until they're discharged. Then circulation, are they on continuous ECG monitoring or not? Usually we'll do it, and then if it's okay out within that 15 minutes, we can take them off. Vital signs. You might have protocol in there. Our protocol for ROT was Q15 minutes for the first hour, then every half hour for the next hour, then every hour until discharge. That was ours. Then peripheral pulses, capillary refill, all those things should be done, and they should be compared to pre-op and intra-op. So we do the vital signs, presence of artificial airway, pain. Don't forget pain. Pain is your fifth vital sign, and it has to be assessed. Urine output, level of consciousness, skin integrity, condition of the surgical wound, presence of IV lines, and position of the patient. So all these things need to be assessed. Okay, so we do our airway, breathing, circulation. Once that is all set, then we go on and we continue to do our assessment, and we make sure that everything, we do each system. So we do the level of consciousness, compare our GCS pre-op to post-op, the orientation. They're going to start to come out of anesthesia, so what's their orientation? And you want to document such. In the PACU, we usually have to document every 15 minutes because that's when we do our vital signs. So we usually document vital signs every 15 minutes with our GCS. And then once our vital signs go to every half hour, then we document every half hour. Now, that's not a full head-to-toe note that you guys have been writing, but it's the vital signs and their level of consciousness, and we give a basic overview of anything that's abnormal or the IV's infusing, whatever. Pupil size and reaction, intake, output, and estimated blood loss, all that should be on there. Then gastrointestinal, do they have bowel sounds? Do they have an NG in? Is it patent? Is it clamped? Is it draining? Presence of nausea, surgical site, what's the dressing look like? We never remove the surgical dressing. The surgeon removes that first surgical dressing. All we do is secure that dressing if it is intact and it's bleeding through. If it's bleeding through, we secure a new dressing, and then we call the surgeon to let them know that it is bleeding through if it's a lot of blood. Pain, incisional, any other pain. They can have pain just from being positioned how they were positioned for so long. So it doesn't always have to be incisional pain. And then any lab and diagnostic test that you needed results from that you're always checking on to see if the results came back. So our post-operative care, as you might have guessed, involves safety of the patient, comfort and pain control, respiratory and circulation status is maintained. We want to prevent any hemorrhagic shock, any infection. We want to promote wound healing. We want to promote gastrointestinal function and monitor for complications and attend to any psychosocial needs that need addressed, and notify the family that the patient's in the PACU, and hopefully the surgeon went out and talked to them. If they did not, you should notify the patient's family. They're in the PACU, they're in recovery. Once they're out of recovery, you can see the patient, but while they're in recovery, we're monitoring all their vitals, and once they're awake from the surgery or whatever, then you can see that patient. So when you think of postoperative complications, do it by system. That's the easiest way. I think if you recognize postoperative complications by neurological system, you're looking for possible CVA, delirium, acute urinary retention, even urinary tract infection, functional. Is there any weakness or fatigue or functional decline? The wound, look for infection, dehiscence, evisceration, delayed healing, hemorrhaging, hematoma. Do it by the system. And I have this picture here once again. Why did I put a picture with the complications on it? I did that so you can take this with you, put it in your clinical thing, and take it to the OT with you. So when you're in the PACU area, you can go by systems and look for each of these complications. And so here's a further list of postoperative complications. And I thought it was good because they had the male patient and the female patient. So when you're looking for the complications, cardiovascular, hypotension, hypertension, arrhythmias, any venous thrombosis, or they might have been in a position that put them really at risk for venous thrombosis, syncope. Then go to your fluid and electrolytes. Do they have fluid overload, fluid deficits, any electrolyte imbalances or acid and base balances? So really, do you understand how important it is for the OT nurse to understand all these systems? Because she has to understand how to assess for hyper and hypotension, how to assess for arrhythmias, what signs and symptoms are they for venous thrombosis, what signs and symptoms are there for fluid overload, fluid deficit, how do I know if they have hyper or hypokalemia, what happens if they have hyper or hyponatremia, and then what signs and symptoms are present with acid-base balance. You have to recognize these things because if you catch them, then we can actually intervene and there won't be complications to the patient. So that nurse that's working in the PACU has to ensure that she understands all these systems of the body and how the complications can arise and how we're going to intervene. So we have to think about internal and external hemorrhages. We have to inspect the dressing and look for signs and symptoms of shock. So do you remember the signs and symptoms of shock? Pallor, decreased blood pressure, weak and rapid pulse, restlessness, and cold, moist skin. So if we see that blood pressure dropping, we're going to look for those signs and symptoms of shock. Perhaps they lost too much fluid. There was a lot of bleeding during it. You have to be recognizing these signs and symptoms that are occurring. Then hypoxia. Do they need more oxygen? Do they need suctioning? Do they aspirate? Unless contraindicated, we place them in that sideline position while they are unconscious. Once they're conscious, then we can change their position. Okay, so nursing interventions to prevent the cardiovascular complications. We're doing those vital signs, usually that every 15 minutes in that stage 1. Compare with preoperative and intraoperative, just like I said. Now, we're going to call that anesthetist or surgeon if any of the following occur. You should note this. Systolic blood pressure less than 90 or greater than 160. Pulse rate less than 60 or greater than 120. Pulse pressure narrows, not a good sign, we know that. Blood pressure trends gradually decrease during several consecutive readings, not a good sign. Change in cardiac rhythm, significant deviation from those preoperative findings, call that surgeon and anesthetist. We need to get them in there because then we can do the interventions necessary to prevent any further complications from occurring. That ECG, is it the same as pre-op? Is there any changes? Assess for hypo and hypertension. IV fluid boluses may be given to normalize the blood pressure. Administration of pain meds may need to be administered for hypertension. We may have to give blood pressure meds, and we have to keep assessing that surgical site for any excessive bleeding. So you're doing all these things in that PACU area. So we're very, very busy assessing these patients continuously. Think about every 15 minutes doing this, recording the intake and output, monitoring any lab results that are outstanding or that we have to get. We want to encourage early ambulation. Early ambulation is the one thing that can prevent paralytic ileus from happening, can prevent DVTs from happening, and it helps with pain control. So we need to get that person up and ambulating as soon as we're allowed to do so. We want to initiate any thrombolytic prophylaxis, pedal pumps, antithrombolytic stockings, heparin injections, whatever it is. We want to monitor for orthostatic blood pressure with increase in mobility. So if we get them up to the bedside commoder, they have to urinate, we want to monitor for orthostatic blood pressure changes. And so we want to change their body position slowly because we don't want that syncope to occur. And so, think about your nursing interventions. What interventions can you perform to prevent GI complications? So we want to make sure we don't feed until there is bowel sounds return. We get them up walking. That helps with prevention of that therapeutic ileus. We're looking for hiccups. Sometimes people get hiccups from the anesthetic, so we may have to give something for hiccups. Even Thorazine or something. We want any delayed gastric emptying. We want to notice that, post-operative ileus, abdominal distension, nausea and vomiting. We do progressive diet, so they might start with clears. If they tolerate clears, then we can go to full liquids. So you want to be observing for these things. And really the best thing is to assess those bowel functioning and assess those bowel sounds and get them up moving. If they have an NG in place, get that NG in, get it to suctioning, and we might have to give antiemetics as well. You want to observe for any hypothermia following that intraoperative area and any fever. We may have to do passive warming, like giving them warm IV fluids and warming blankets. And then oxygen therapy and deep breathing exercises. Oops, sorry, I went too fast. So we're looking for respiration, hiccups, circulation, pain management, and fluid and nutrition. Skin integrity and wound healing. Really inspect approximation of edges, intactness of staples or sutures. You're going to count those when you do it. So if there's 7 sutures in there, you write there's 7 sutures. That's very important because if they get transferred to the medical ward and it's time to get those sutures out and they're still in the medical ward and the doctor only took 6 out, sometimes the skin is thrown over the 7th, they don't recognize that, and that gets stuck in there and then they get an infection. You always document how many staples and sutures are in place. Look for redness, warmth, swelling, tenderness, and then the stages of wound healing. The inflammatory stage, remember that clot forms, swelling occurs, and phagocytes ingest debris. That lasts about 1 to 4 days, then the proliferative phase, and finally the maturation or remolding phase that can last 21 days or even longer, especially for those with diabetes or immunocompromised or those with delayed wound healing, such as our gerontologic population. And also, there's primary intention, secondary intention, and tertiary intention. Remember, primary, the wound layers are sutured together, the wound edges are well approximated. Then granulation tissue fills in the wound, skin edges are not approximated, and it's a slow process. And usually secondary intention occurs in maybe a pressure area that's healing, and then tertiary intervention is approximation of wound edges is delayed secondary to infection, and that's not what we want. So we have to be, really monitoring for signs and symptoms of infection and teaching the patient how to do so. Now, have you ever heard of wound dehiscence and evisceration? Dehiscence is just separation of those wound edges. So if there's staples in place, the staples let go, but nothing falls out. With evisceration, the wound completely separates and organs protrude. I actually had a patient one time that sneezed and her intestines came out. And that usually occurs within 7 to 10 days following surgery, but I'm serious. I had just admitted her from the PACU on first day 1 post-operative day. I got her right on the medical surgical ward. I went in to do my assessment. She sneezed and out came the intestines. So I'm telling you that it can happen. That's wound evisceration. Now, dehiscence is where it lets go, and you still have to let the surgeon know so they can reattach it. So here would be dehiscence, the letting go of that skin, but nothing comes out, and then evisceration, things actually protrude from the wound. Now, we want ambulation shortly after surgery. Usually, they'll order, out of bed, ad lib, when tolerated or when vital signs are stable, but it has to be shortly after surgery. We want to prevent the DVT, or we want to prevent any paralytic ileus. And the client who has received spinal anesthesia remains flat for 6 to 12 hours, and that's important. And then bowel elimination. Constipation may develop after the client begins taking solid food, and we have to be alert for paralytic ileus. That's when the intestines are paralyzed and peristalsis is absent. So you'll have absent bowel sounds, and that can lead to peritonitis. So I'm telling you right now, we have to be assessing for those bowel sounds, and the patient should not take in anything by mouth until those bowel sounds return. We should not be giving them anything. And then acute gastric dilation, the stomach becomes distended with fluids, so we have to be alert for any abdominal distension. And then urinary elimination. If the patient or client cannot void within 8 hours after surgery, we have to call and get an order for a catheter. We have to cath this patient. Now, sometimes the surgeon will even write the order if no void post-surgery 8 hours, then cath patient, and he might say not even to put indwelling catheter in situ, he'll just say straight cath patient, because sometimes that first straight cath will actually wake up that bladder and they'll begin to void after that. So we have to observe for restlessness, lower abdominal pain, and discomfort, because sometimes they can't even feel that urge to void. So you really have to be alert for that distension. Remember, if you can palpate a bladder, then it's full and it needs emptied. Also, in the postoperative phase, we have to be alert for drains. So I want you to be alert for these different drains that can be in situ. You really have to be aware of them. Sometimes it's just like at the top there, the top left, that drain is a Penrose drain. And then you have the JP drain and the Hemovac drain. So you have to know what these different drains are and how to utilize them and how to care for them. Because a Penrose drain, it's for minimal drainage and it just goes on a little gauze pad. A JP drain, you have to squeeze it, because if it's not squeezed, then it won't have that suction. It won't work by gravity and it won't suck out the fluid. Now, a Hemovac drain also has to be squeezed, and it works that same way. So you have to know these different drains. And then you have to be aware of the analgesics. We have to provide pain and pain control to ensure we don't alter vital signs like the blood pressure and heart rate and things. So we want to give analgesics. Sometimes we'll have an epidural catheter in. You guys really don't use them very much here. And you guys really don't use patient-controlled analgesia here. But in the States or elsewhere, you may see a PCA pump. Now, we do what is called an Alderette scoring system. It is a modification of the APGAR scoring system used with newborns, okay? And it takes into consideration the patient's consciousness, activity level, respirations, oxygen, and circulation status. A score of 9 to 10 indicates readiness for transfer. Some institutions may accept a score of 8. I've never worked in one, but when I was doing research and I was looking to see and ensure that we still use the Alderette scoring system and that it's used here, then I was seeing that some places have decided to use 8. And I guess it's because they do a lot of same-day surgeries and it's hard sometimes to get the activity level up to where it should be. So I've always seen it 9 to 10 indicates that readiness to transfer, either to discharge home or to transfer to the ward. So we look at and we give a score. You know, if they're fully awake, they get 2. If they're arousable only the voice, they get a 1 and unresponsive 0. Then we look at the extremities. Are they able to move them? 2 extremities and no extremities, then able to deep breathe and cough. Sometimes the patient never wants to do that if they had abdominal surgery, and then dyspnea and apnea. So you're looking at all these things, and then oxygen saturations and circulation. So you can see how it's a modified thing of the APGAR score, actually. And so what we do is we determine the Alderette score to see if they're ready to move from that PACU to be discharged either to home or to the ward. Now, discharge phase 1 is a pain airway. Patient's awake, hemodynamically stable, no respiratory depression, oxygen sats greater than 90, pain management's under control. We give the report, and there's no excessive bleeding from the site. We're ready to go. Post-anesthesia phase 2 is an inpatient setting. The nurse can focus on preparing the patient for managing care at home. So they might go to a rehab or home, and so equipment would include the equipment required to care for the surgical procedure condition of the patient. So they might go to a rehab facility where they might need like a CPM machine if they had a total knee or something like that. Then there's ambulatory surgery, and that's like same-day surgery. You don't have it a lot here, but same-day surgery, the patient has to be mobile, up, moving around, already voided, and we give them written instructions, and boom, they go home. Okay, so we'll talk about the drains in further detail when we have class, because I want you to be aware of these drains and how to use these drains. So we will talk about those further in class, because I know I didn't talk a lot about those, but we will. All right, thanks, guys.